Welcome to Beyond Appreciate Rex, a standardized approach to consultation communication for new residents. I'm Shannon Martin. I'm one of the core faculty members of the Internal Medicine Residency Program, as well as an academic hospitalist at the University of Chicago. I will be narrating this presentation in collaboration with my colleague, Dr. Kemi Carter from Emergency Medicine, who is the Director of Undergraduate Medical Education in the Section of Emergency Medicine and the Assistant Deans of Admissions for the Pritzker School of Medicine. The objectives of today's talk are to discuss the importance of structured communication and consultation, as well as the impact on patient safety, to review techniques for safe and effective consultation communication, and to provide an introduction to a validated model for structuring a consultation, the 5 C's of consultation communication. How do you define a consultation in clinical medicine? Consultation is officially defined as the process by which one physician seeks the formal recommendation of a specialist regarding the care of a specific patient. The consultation process, if it is to be done safely and effectively, requires a sophisticated skill set that encompasses multiple aspects of communication. A consulting provider must provide a synthesized clinical context for a consultant in order to structure their argument and persuade the consultant of the need to obtain their expertise, all the while building and respecting the relationship between the two professionals. All of these skills are especially important given that many consultations are done with time constraints, often over the phone, and with healthcare professionals who may come from a different medical cultural background and have different priorities. So why is it important for us to discuss the process of consultation? Medical errors are frequently attributed to breakdowns in communication. Between 2004 and 2012, communication failure was the leading cause of sentinel events, responsible for 66% of all events. It is very evident from the literature that standardizing communication between healthcare providers can help mitigate these types of errors. For example, standardizing handoffs between physician teams during transitions of care. There is a growing body of evidence that the same is true for consultation, and that standardization of the consultation process would promote efficient and safe communication between medical care teams. Furthermore, there are specific skills, attitudes, and behaviors that have been demonstrated to be desirable qualities in the consultation relationship. Many of these aspects deal directly with communication, identifying the reasons for the consult, the urgency of the consult, and how that communication should reflect the urgency. Understanding the characteristics of the providers involved is key, the roles of the consultant and the referring provider, and how the characteristics of these providers may affect the consultation, time, schedule, or other obligations such as operating room or clinic time, and relevance of the question that is asked. And finally, mutual respect and collaboration is vital to a successful consultation, working together and providing education without condescension or arrogance. A quick note on curbside consultations. Curbside consultations are defined, in contrast to a formal consultation, as an informal process whereby a consultant is asked to provide information or advice about a patient's care without completing a formal assessment of the patient. In comparing curbside to formal consultations, it has been demonstrated that there are significant differences between the two processes. When physicians request a curbside consult, information provided to the consultant during a curbside is often incomplete or inaccurate. When consultants give recommendations on a curbside, these recommendations will most likely differ from those that they would have provided in a formal consultation, and these differences can frequently result in changes in clinical management for the patient in question. For these reasons, curbside consultations should be avoided and are discouraged at the University of Chicago. So when you have determined that you need to formally seek the expertise of a specialist regarding a question in the care of your patient, the next step is prepare yourself to request that consultation. It can be a daunting task, especially as you are just starting out in residency training, to consolidate large amounts of information about a patient and their course into a clear and useful consultation for a specialist. This is where we turn to a model to help organize and structure your consult, the 5 C's of consultation: contact, communicate, core question, collaboration, and closing the loop. This model was developed by Chad Kessler and colleagues and has been shown to be very effective in helping organize a consult. It has been tested and validated in a randomly controlled trial in residents in emergency medicine and shown to increase the effectiveness of consultation communication. We will discuss each of the 5 C's in greater detail as we go through how best to prepare for and organize your consultation and view a short video clip for each step demonstrating an example consultation communication that nicely incorporates each of the 5 C's. The first C of the 5 C's is contact. This is the first communication a requesting physician will have with a consultant. Most likely, you will have called or paged the consultant, who will then call or page you back. In this step, you identify the consultant by name, role, and service, confirming who you are speaking to. You then ensure the consultant knows who you are as well, identifying yourself by name, level of training, and the service you are calling from. as well as identifying your supervising or attending physician. Please watch the following video clip and note the parts of contact that the intern gives to the consultant in the example.
Hello, Shannon.
Hi, yeah, this is she, Paige.
Yeah, hi, Shannon. You're the CCU fellow currently, right?
I am, yeah. Great, this is Sam, the intervention.
I wanted to consult you on our patient, Miss Debbie Jackson, MRN 987654 in room 305.
The second of the 5 C's is communicate. This is where you tell the consultant about the patient in a succinct but complete enough way to explain why you are requesting this consult. In this step, provide the essential patient identifying details, name, age, MRN, and location, offer a confirmed or suspected diagnosis, supplementing that with the relevant clinical case specifics, a brief history, pertinent exam, lab, or imaging findings, and what has been done thus far. It is also very important for the consultant to know if this patient has an existing relationship with the specialty team. For example, this is a patient of Dr. Taylor in your department, or this patient was just discharged from your ward service yesterday evening. Speak clearly and be pleasant, and remember, your goal is to clarify the story for the consultant, not keep them in suspense. Please watch the following video clip and note the clinical details that the intern gives to the consultant in the example of communicate.
She's a 62-year-old lady with CHF whose current state is concerning for acute decompensated heart failure.
She came in 2 days ago with shortness of breath and initially diarrhea swell with late 640 BID.
About 2 liters, but today her mental status is poor and she's cold on exam.
The third of the 5 C's is the core question. This is the part of the consult where you ask the consultant for their expertise. You specify the need for the consultation in the form of a question. It is key at this step that you clearly identify the question or request, the reason why you are asking that specialist to contribute to the care of your patient. It is also critical at this step that you identify what the expected time frame is for the consultation. If this is an urgent or emergent consult that needs to be seen as soon as possible, versus a consultation that is still important, but perhaps less pressing for the immediate care of the patient. Please watch the following video clip and note how the core question of the consultation is presented by the intern to the consultant.
My attending, Dr. Carter, wanted the CCU to evaluate her for any need for inotropic support as well as possible transfer to the CCU. Oh, and I actually just got paged that her BP and urine output are both dropping, so we'd like to see you to see her as soon as possible, please.
So your question for us is specifically about CCU management for inotropic therapy for acute decompensated heart failure.
Yes, that's correct.
The next C in the 5 C's is collaboration, in which you may solicit any initial recommendations or requests from the consulting physician and agree upon a mutual plan of action for the patient. This is a discussion between you and the consultant, and you should be open to any initial suggestions, recommendations, or requests from the consultant that can assist them in providing the consultation at this time. Please watch the following video clip and pay attention to how the intern is open to collaborate with the consultant through their discussion.
Okay, I'll come see her as soon as I can. In the meantime, can you go ahead and put a Foley in to better monitor her urine output? And please evaluate for any other causes of hypertension as well. I'll be at the bedside in about 10 minutes.
Okay, I'll get that Foley put in right away.
And rule out other causes, and I'll try and be at her bedside to evaluate her with you.
Okay.
The fifth and final of the 5 C's is closing the loop. This is the step in which you ensure that everyone is on the same page with respect to the plan of care moving forward for this patient. This also helps to ensure that you will remain in touch regarding any changes in the plan. An important part of continuing to build this relationship is thanking the consultant for their time and help. Please watch the final video clip of the consultation scenario and watch how the intern ensures that she closes the loop with the consultant about the next steps in patient care.
Hey, Sarah.
Oh, hi, Shannon. Thanks for seeing Miss Jackson.
Hey, no problem. Her exam is definitely consistent with acute decompensated heart failure. She's cold and wet, and I agree. I think the best place for her is the CCU. So I would recommend that we transfer now. So if you want to go ahead and call the team and give them a sign out, I'll have them put in orders, and I'll work on getting her a bed.
Okay, great. Thank you.
And if you could let your attending know, too, that would be great.
I'll do that.
Okay.
Thanks again.
Thanks.
So to review, the 5 C's of consultation communication are contact, communicate, core question, collaborate, and close the loop. Use this model to help prepare, organize, and structure the information you have when calling a consultation for a patient that you are caring for. Having this structure in your consultation communication will help you feel more prepared, your consultant to understand your consultation question better, and will improve the consultation communication between you and the consultant, resulting in better communication and better care for our patients. A few quick points about the consultation policy at the University of Chicago. This policy, which can be found on the intranet at the University of Chicago, details the policy and procedure with which consultation communication is expected. We will highlight a few points here, but please go back and read the policy in its entirety. Several of these elements are closely aligned with the 5 C's that we have just discussed. First of all, it is explicitly stated in the policy that curbside or informal consultations are meant to be avoided. There are specific instructions as noted regarding the procedure in requesting a consultation, the details of the first 2 C's, contact and communicate. When you are requesting a consult, begin by placing an order into the electronic health record and noting the consult in your documentation. Consultations are requested at the University of Chicago via text page and subsequent phone conversation, and the policy outlines the appropriate details to be included in the text page. Finally, there are guidelines for the appropriate timelines for consultations, an important element of the third 5C, core question, and specifying a time frame. Routine inpatient consults should be completed within 12 hours, stat consults within 2 hours, and consults from the emergency department within 1 hour. So the take-home points for today are that consultation is a formal process in which one physician seeks the formal recommendation of a specialist regarding the care of a specific patient. Requesting a consultation is a very specific type of interprofessional communication, and many medical errors can be traced back to a breakdown in communication between providers. To help mitigate this potential for error, you should avoid informal curbside consultations and use structured communication frameworks to prepare yourself and organize your request for a consult. And when you request a consult, remember the 5 C's of consultation communication: contact, communicate, core question, collaborate, and close the loop. This concludes this webinar on best practices in consultation communication for new residents.